inshallah, when we're resuming again. So the meeting program is really focused on left heart catheterization. So when you hear cardiac catheterization, everything should come to your mind. Not only just left heart, but right heart catheterization and structural heart diagnostic and interventional catheterization. The course will eventually cover all the following points. We'll start by basic diagnostic coronary angiography. And then once we finish that particular part, which may take a few lectures to just finish the basic diagnostic coronary angiography part of it, we'll move on then to advanced diagnostic coronary angiography, including graft studies. And then we will move on a separate lecture to interventional diagnostic coronary procedures, which include IVUS, OCTs, IFR, FFR, DFR, whichever you call it. But they're all diagnostic procedures, but they're regarded as interventional diagnostic procedures. So if you don't have capabilities to do interventional procedures in your cath lab, you should not be doing interventional diagnostic procedures. That should be done in an interventional center. Most of the places now have the capacity to proceed from diagnostic to interventional procedures. So most of the cath lab would have diagnostic interventional procedures as well. And then we shall move on to basic coronary intervention, which basically most of our colleagues would have to accomplish by the end of their training to be competent in doing basic coronary intervention. And then after that, we will finish by moving on to advanced coronary intervention, and that will include high-risk cases, what we call complex, high-risk but indicated procedures. CHIP is a word for it. That includes CTOs and include left main, heavily calcified lesions, and the more aggressive end of intervention need to be done in multiple lectures, and most likely will be involving more colleagues to give the opportunity for everybody to contribute. This is a great opportunity. We will not be covering the indication of the procedure. That is before the patient actually comes to you for the procedure. The indication would be absolutely necessary. There shouldn't be any vague ideas about it. It should be very clear that the procedure is indicated, and the patient selection has to be appropriate. I don't know, my camera is not working. I don't know if you can see me, but are you able to see me at all? I can see a few of you.
No, we don't see your camera.
I don't know. I turned it on, but for some reason, maybe there's no camera for now. But we'll deal with that in future, inshallah. I'll just move back to my presentation again. If you don't mind, the Sugi to admit people as we go.
Yes.
Yeah, great. Thank you. Can you see the presentation now?
Yes, very clear your screen.
Okay, great. So again, as I said, patient selection is very important. For the sake of today's discussion, we are going to talk about elective stable patients. We're not going to talk about emergent indications for cardiac catheterization. As people move on training, they start usually by doing elective patients and contributing to that. And then slowly they can step into emergent cases where speed is at most important. So it's important for any trainee, anybody starting up, to recognize their limitations and to know when to escalate to their colleagues, ensuring patient safety. That's the most important thing. The rule number one in medicine is cause no harm. So it's very important that we recognize where we are in the ladder of training, what are our limitations, what are our capabilities, and ensure patient safety at all times. If there's any supervision required, then you should not hesitate to provide supervision or receive supervision. Knowledge will always have somebody superior, so there's no shyness about that. I looked into the numbers of procedures needed in the British guidelines or British training, I should say, for coronary angiography. In the old training system, it used to be 250 diagnostic angiograms during cardiology training has to be done if you're going to go through for interventional procedures. But in some cases, to finish cardiology training, you should still you should have done 250 cases. But nowadays, it's not required to do any coronary angiography to finish basic cardiology training. If you want to pursue cath lab training and coronary intervention, obviously that's a different talk. So everything starts by taking history. So we're not going to talk about detailed history. Most of you are very competent, capable colleagues, and we just focus on the most relevant, important parts of the history, including previous cardiac catheterization. So if patient had any previous procedures somewhere else, it's very important that we get hold of those images, ideally, or at least reports, to know what has happened during that procedure, what was implanted, which access they went through, whether there was complications. And we take the history of the patient experience who went through this. Were they in pain? Did they feel any difficulties? Or have they had any opinions about the procedure that they went through? So that's a very important part. And if there's any complications or difficulty that was explained to them, for example, they had to switch from radial to femoral or femoral to radial, or they spend a lot of time trying to get the radial. These are all helpful information that you have to extract from chatting to the patient. It's very, very important for any physician talking to any patient before doing anything to them or writing any medication is to know their allergic history. And that has to be clearly documented, whether it is medications related or substance related. It's also very important to record the antiplatelet or anticoagulants that the patients are taking. Most of us are now a lot more comfortable doing just diagnostic procedures on most of anticoagulants, especially when we're going through radial route. Up to years recently, we used to stop it for diagnostic procedures. Some of our colleagues are still brave enough to continue anticoagulants and give heparin on the table while doing an elective patient for intervention. And I think that's a bit too much. I think we always blame ourselves if anything goes wrong, and we have to take all the steps. Stopping anticoagulation will carry very small risk in most of the cases for thromboembolic disease in those patients taking anticoagulants regularly if it was to be ceased for the cardiac procedure. And it's also very important to know the appropriate doses and the frequency. In terms of antiplatelets, patients will say, a lot of patients will say, we are taking antiplatelets, we're taking aspirin and something else. There shouldn't be any ambiguity about that. We have to know our patients, and that should have been done way before the patient arrives in the cath lab. So that has to be very clear. The timing of the doses, the loading, whether they were loaded or not, whether they were fast loaded or slow loaded, these are all very relevant information that has to be extracted. Examination, going to the cath lab has to be focused on relevant parts that you're trying to do. First of all, you ensure your patient is ready hemodynamically for the cath lab. So selecting your patients, say a lot of patients do present with, say, an acute coronary syndrome which we're not talking about the acute ones, but you have to make sure that your patient is not in pulmonary edema or can't tolerate your procedure, and you're not actually causing them harm by putting them on the table early. So ensure your patient is ready hemodynamically. It's important also to assess all the potential access sites. I know most of the time now we go radial, so we check the radial and we move on, but we really don't know what we're going to face going up that radial artery. We may have difficulty in the brachial bifurcation or further up, and we may end up switching. So we have to be ready to switch, and we have to know which vessel to move on to next, depending on your level of confidence and the patient risk factors and the presence of anticoagulation on board, which we often give on the table when we start radial access anyway. But we have to put it in a timely fashion that it is safe for the patient. So it's very important that once we take the radial access and we move on, some people do give radial heparin, and some people give it up in the aorta, some people give it in the vein. You tell the staff to give it in the vein. Generally, 90% of times we are confident once we are inside the radial artery, once the sheath is placed, we say go ahead and give the heparin doses needed for diagnostic coronary angiography for radial access. And the heparin is really for radial artery patency, not necessarily for the diagnostic part itself. You have to go through all the basic laboratory and imaging investigations and all the bedside investigations, including ECGs, current and old ECGs. You have to understand your patient deeply. You have to ensure that the blood tests are all reviewed. And how many times, I'll tell you, we've seen people coming to the cath lab with severe iron deficiency anemia, and they were actually, that was the cause of their symptoms. And that's an inappropriate one to miss before patients come on the table. If patients are emergent and they have to go to the cath lab, that's a different talk. But somebody who's stable, you must check their hemoglobin. You must ensure that this hemoglobin is not due to iron deficiency anemia. And if it was, you have to make sure that the patient had relevant investigation to their situation, which may include scans and scopes. Renal profile is an absolutely essential test, obviously because of contrast given to the patients. And you have to prepare patients to the procedure from the renal point of view, depending on their risk for contrast nephropathy. You have to ensure there is adequate plans and all the investigations have been completed for elective patients. For emergent patients, it's a different talk. You must review their x-rays. You must know if there's any mass on their chest x-rays. I'll tell you, many times we have seen patients come to the cath lab, not once, not twice, many times. Patients come to the cath lab, nobody had looked at their chest x-rays. You can find sometimes a mass on their lungs, or that was missed. And sometimes patients actually had CTs, and people did not look at the report. They only were informed that there was significant disease in their LAD, and they were interested in that particular part only, but they didn't actually go through the actual report. Whether they tell you verbally or not, you must read the whole report and ensure your patient is ready for your procedure, because you are responsible about it. Any previous relevant chest or vascular or cardiac imaging must be reviewed if it was done prior to the cath lab. Talk to your patient. In a lot of settings, we just run around and we just appear in the cath lab. That's very inappropriate. You should always introduce yourself to the patients. You should always meet your patients way before you meet them on the table. One of my trainers in Canada would not allow me to touch any patient if I have not met that patient in the clinic or in the ward. Even though I was a pure intervention fellow, had nothing to do with the clinics. But if I was going to do any intervention on any patient, I must meet them and give them the chance to know me. And that's really natural. because people that you meet in advance and you know them, it gives you comfort when you meet them on the table side, and then you know who's going to do the procedure, and that's dignified. Talk to your patients, explain to them what you are expecting from them. Tell them not to move, keep their arms steady, breathe nice and slow, try not to talk. Ask them, how do I call you? What's your name? What do you want me to call you? And if the patient say, I want you to call me this, say, we will be talking a lot among ourselves in the cath lab with the staff, but if I really want you to talk back to me, I will call you by your name. And that's very clear communication skill. It's very important that you say that to the patient, so the patient doesn't suddenly start talking or moving or jumping, expecting that you're actually talking to them, which can affect the procedure adversely. So you have to be very clear. And you have to explain to the patient in simple words, not in medical words, simple words that the patient can understand how you're actually going to do the procedure. You say, I'm going to start by giving you a local anesthetic over the access site, and you will feel a little scratch or pinch or a little needle, and then you'll feel some heaviness while I'm infiltrating local anesthetic. And after that, I'm going to feel your artery and go through, and most likely you won't feel much apart from a little bit of gentle movement, but there shouldn't be any pain. If there's any pain, please do let me know, because pain is an indication of something that is going wrong during access. You may feel warm sensation in your hands if you're accessing the wrist, because sometimes the local anesthetic that you're giving can actually get into the radial artery and goes distal to the hand and gives quite a warm sensation in the hand. Reassure them and tell them that this is going to be transient and going to last for about 10 to 20 seconds. Excuse me. Some patients may feel a warm sensation in their hands or their forearm if you're giving them contrast while you're navigating your way up in case of difficulties. So ensure you talk to them about it so they're expecting what they are going to go through. Disugi, would you mind muting?
فليعبدوا رب هذا البيت الذي طعامهم من جوع وآمنهم.
I have it here. Okay, that should be that. So discuss the benefit and risk of the test. Anybody going through a test, you have to explain to them what test you're going to do, what is the benefit of that test, what are the risks of that test, what are the potential alternatives to that test, if there are any alternatives, and the alternative limitations, and the limitation of your own test, and why is this test indicated. Ensure that they actually give you feedback to what you're saying to them. You can ask them to repeat what are the risks that I just mentioned to you. I find this particular part quite difficult in different healthcare settings. Some patients actually in some healthcare settings prefer not to know. But your duty as a doctor is to explain the minimum information that you think the patient should know about. Some patients want to know everything. So it's important that you ask them in details. Most of the health care settings, you are required by law to explain fully the risks and benefit of the procedure. Whether the patient agrees to do it or not to do it, that's their decision, not your decision. Because remember, they are going to sign a consent that they were fully informed, and you have to ensure that is the case. Unfortunately, a lot of times I've seen, especially in some healthcare settings, we don't tend to inform patients of full details, and that's failure from our part. Our duty is towards the patient. That's number one duty. The family is very important to explain to the family, but the family's decision of not telling the patient the details is actually an absolute wrong thing to do. If the family want you not to tell the patients, you are not obliged to do that. You may do what they say, but if anything goes wrong and you go to the court, you have not actually explained what you said to the patient. And the very family that told you not to tell the patient will be witnessing that you did not actually tell the patient that there's a risk of stroke or the risk of death. The word death has to be mentioned. And when we talk about the risks of coronary angiography, we say, okay, it's probably 1 in 1,000 risk of stroke, 1 in 1,000 risk of heart attack, and 1 in 10,000 risk of death. You're actually talking about general risk, general numbers. But do you think the patient is interested in those, or more interested in your own center risk, in your own risk that you actually go through? How many patients have you done last year, and how many of those had strokes? This is your data. So it's very important to be transparent and honest. A lot of times we say these numbers because they do cover us in general. But if you sit down and ask yourself, did you actually deliver the right information for the patient? Probably not. Procedures are becoming much more risky because patients are living longer, our patients are older, and have much more complex medical comorbidities. And therefore, we have more potential risk, probably a lot more than 1 in 1,000. And particularly when it comes to MI peri-procedure and what the definition of MI peri-procedure is, and how you communicate that to the family and to the patient or in the court setting. So you have to explain the alternative procedures, as I said, and give the patient chance to make choices, make their own decision. And if they need time, give them that time they need to make that decision. And you need to also understand the local guidance of potential requirement for further escalation, which may include blood transfusion or even resuscitation. If there's any advance information from the patient that if that particular patient got into cardiac arrest situation, he does not want to be resuscitated, then if you do resuscitate them in some healthcare settings, that will be considered as an assault. So make sure that you understand the local guidance and the patient's own wishes, especially if it is documented and legally written. When it comes to blood transfusion, we probably are all familiar with Jehovah's Witnesses, who will be reluctant or even refusing completely to receive any blood transfusion. We had patients who had bleeding during cardiac intervention and their femoral artery, requiring blood transfusion, but they clearly refused. But at the end of the day, you are supposed to consult with them. You're supposed to explain to them what are the risks. And if that situation happens, what you would normally do and what they would like you to do. So it's very important to document that and explain it to the patient and the family. Because if the patient dies, the family will be with you. So you have to make sure that there's some witnesses from the family and some witnesses on your healthcare side as well. Language barrier, I find that really unfair for a lot of patients. We do rush to do what we need to do for the patients, but did we actually explain enough to the patients? Language barrier is not the patient's problem. It is our problem. We should overcome this barrier by different tools, either by having translator services paid by our healthcare system or finding some sort of communication with the patient, whether it is written or audio or visual communication to explain what is needed to be done. And that has to be on an official ground, not on a friendly kind of request from a friend who speaks that specific language that could you please pass by and explain that. The interpreter has to sign part of the consent form. So it's very important that that interpreter is officially requested by your healthcare system, not a favor from a friend or somebody passing by speaking that language. The issue of incapacity is a very complex one, especially in Western healthcare systems, where people have to be assessed if they have capacity or not to sign the consent form. And if they don't have the capacity that they could not sign the consent form for, you have to document and ensure that the proper assessment for incapacitated person is in place. You have to also involve other colleagues, other healthcare professionals to ensure this is discussed. And if needed, if it's an emergency, you would need two physicians to sign the consent form. And there's a specific type of consent, not the regular one that we get our patients to sign. Setting up your cath lab is very important thing to do. A lot of in many healthcare settings, people depend on cath lab nurses to do it. When we were in training, we used to be part of the preparation. We just go in once you have time, you finish your report of the previous patient, and you're ready to move on. You can go ahead and help with the preparation of the table. Some staff would actually prefer to take the time to prepare the patient and ensure the patient is privately covered from being exposed to any strangers before they actually ask you to step into the room. So you have to understand what is the local arrangements in your place. Prepare and sterilize intended access sites. So if you felt the radial pulse and felt the femoral pulse and you think you're going to go radial, then prepare the radial pulse, sterilizing the radial pulse, and draping the patient with the most recent drape that we have are 4-hold drapes that covers the 4 access sites, right radial, left radial, right femoral, and left femoral. But sometimes you have to modify your drape depending on how good it is to make sure that you have the right cover for the right access site. And then understand your cath lab machines, whether this is a single plane machine or biplane machine that you're using. You need to know how to use it. There are some machines that are operated by the doctor themselves. They have to move the table, and some of them are operated by radiographers. The radiographer operated ones, a lot of them, actually, the controls can move over to the operator side. And a lot of operators are trained to move the table, and they feel more comfortable because they don't need to tell somebody else what angle they want and how they want the table moved or raised or lowered, depending on what they want. They just do it. So they have to get the control on their side. And if you think about the cath lab table, if you're standing on the radiographer side and you push the knob forward or north, the camera should move to the cranial view. But if you take it as it is and you move it to your side, if you do the same movement that you see, the camera is going to move on a different direction that you can see. So you have to prepare your setting to the operator side and use the machine appropriately, because these things take time. Every movement of the machine takes time. Everything you do takes time, and you have to be efficient so you can continue to do your procedures on an efficient way and go through your patients safely without rushing the actual procedure. Preparation of your contrast manifold is very, very important part of the preparation. There are different manifolds. There's automated contrast management system that you just press either contrast button or flush button, and it will just do whatever you're telling the machine to do, and it will count the amount of contrast and measure it and have it ready for you at the end of the case, and it will actually save quite a bit, the automated ones. The manual ones, you have to be very careful because it's just in your hand. You can withdraw as much contrast as you want. You can inject as much contrast as you want, and you may not be aware of the numbers while you're actually doing it. While the automated ones have a screen that can actually tell you how much you're using every time you inject. and it helps to reduce the amount of contrast used. Labeling drugs on the table is, again, we've seen disasters happening on the cath lab and losing patients for simple mistakes, for medication that are not labeled and given in the wrong time to the wrong patient. So it's very, very important. Nowadays, most of the cath lab pre-sets have packages that have labels already on the syringes. Some of them actually have colors for nitro, for heparin, for verapamil. They have different colors, and they also have some other colors for miscellaneous that you may use, like adrenaline or any intracardiac medication you would like to give later. So it's that helps a lot to ensure the patient remain safe despite rushing or running around in difficult scenarios when there's cardiac arrest or difficult problems. We tend to kind of our focus shift from the basics, but this is an essential part. One helpful tool as well to make sure that the syringes aren't mixed, so you're not flushing with 10 ml syringes, you're flushing only with 20 ml syringes, and the 10 ml syringes are saved for drugs if you don't have them pre-colored. The catheter sizes, choices, that's very, very variable. As we all know, I'm not going to go into the details today of this, but basically the commonest sizes that we use in the cath lab is 5 and 6 French sheath and 5 and 6 French catheters. The sheath is usually either 5 and 6 sheaths that you put in the radial artery that is that can fit 5 or 6 French catheters. Sometimes you can't even fit that in small ladies or severe radial spasms. You may end up putting a 4 French sheath to complete your procedures with 4 French catheters, but you have to ensure that you have those catheters available to be able to complete your procedure. The shapes, I usually start with the right GR4, which is the same for radial and femoral. So I usually take a GR4 out. And then as soon as I feel that my wires and my catheters have reached the ascending aorta safely without difficulty, I do assess the width of the ascending aorta by passing my wire around the ascending aorta and just looking at the movement and where the external aortic arch is as compared to where the internal aortic arch edge is. You can tell how wide the aorta is, and that will tell you which catheters you're likely to be able to use successfully for the left system. The right system, usually JR4 is usually enough. Most of the takeoff from the right coronary artery, from the right coronary cusp, is usually just a straight horizontal run that the GR4 runs into without any difficulties. There have to be some manipulation, which we'll discuss briefly, but sometimes the origin of the right coronary artery is ectopic, and it could be more anterior or more downwards, which makes it very, very difficult to engage from with a GR4 catheter because of the shape of the tip of the GR4 catheters. First of all, I generally say get your wire down to the right coronary cusp. The right coronary cusp is usually lower and to the right, and the left coronary cusp is usually upper and to the left. So if you feel that you're going more to the right and it's going lower, then you're likely to be in a right coronary, in the coronary cusp, in the right coronary cusp. And if you have it already in the right coronary cusp, then you advance your GR4 into the right coronary cusp, facing onto the left side. And as soon as you take out your wire, flush your catheter, I have to say de-air the catheter first, and then ensure that the pressure is normal pressure tracing. Then you start your manipulation to engage the right coronary artery. And usually it can be quite mobile during radial access. In particular, the catheter is not as stable as when you come from the femoral axis or even the left radial axis. The right radial axis is a lot more mobile. GR4 is usually pointed to the left system, making sure that the tracing is the pressure tracing is normal. The waveform does not show any dampening or ventricularization, and then you could start manipulating your catheter by pulling it a little bit from the cusp and then turning it, torquing it towards the right of the patient. That torque is usually achieved by counterclocking your GR4. And the final movement to engage the right coronary artery is by torquing, not by pulling or pushing. So the first movement has to be pulling or pushing, depending on what level you want to be. And then you start torquing your catheter to get into the right coronary artery. You can try counterclockwise or clockwise rotation, but usually it engages by a clockwise rotation. The left system is usually engaged by Judkins left, which usually on the radial side is 3.5. Some centers use GL4, but it can be slightly too long and it may end up going under the origin of the left main artery. That is usually suitable for a bigger approach when you're coming from the femoral artery as you reach the outer curvature of the ascending aorta, while when you come from the radial side, you will be coming closer to the inner curvature of the ascending aorta, and you don't need as much bigger size. And then you can escalate as you need to. And ensure before you do that, your catheters are flushed and ready. These are two different cath lab types, the biplane types and the single plane type. Just be familiar with the paddles and how they're moved, how you bring them, if you're going to operate. And from the operator perspective, I find it a lot slower to use the biplane. But from the patient perspective, you end up using less contrast if you were doing it correctly and using the appropriate catheter engagement and the appropriate breathing holding maneuvers that you don't have to inject too many times. Remember, we did one particular patient with only 8 mils. We did the right and the left system with biplane diagnostic pictures. The lady was a bit small, so we didn't really need to inject too much. And you basically take one injection on the right system, and that gives you 2 pictures. And then you take 2 injections on the left system, and that gives you 4 pictures. So it's pretty effective in saving contrast, but it's pretty painful to prepare it and make sure the patient is right in the center in biplane, and both cameras are in the right field. So you have to ensure that the cardiac cellway is sitting right on the center of the field of both cameras at the same time before you do anything. And once you have set your cameras on the same place that you want them to be, then the height of the table will not change throughout your diagnostic investigations. Because once you change the height of the table, then everything gets changed again. While it's a lot easier to work with a single plane catheter, single plane cath lab, you just use one C-arm and you start moving it around. As we know, the C-arm, this lower part is called the radiation source, and the top part is called the image intensifier. And the views are based on the position of the image intensifier to the patient. The patient will be lying in the middle of the table, and the image intensifier will be anterior to the patient. And that's why most of the views are anterior views. Sometimes we do a posterior view, but that's very rare, and it's extreme angle. We don't tend to do that anymore. Then we'll talk a little bit about accesses, and we'll probably stop at that at the end. We will not go into femoral axis or brachial axis yet, as this needs more time and more details, and they're important to do them in a safe way. When we started training many years ago, radial access was only new, so we didn't really do much radial at the time. We did everything femoral, and we were very competent in femoral access. As we moved on, we've seen how things have changed to the better for the patient. But for us, femoral access became a nightmare because we're not used to it anymore. We don't do it very frequently, and we're seeing a lot more complications from femoral access that we didn't really see as much in the past. So radial artery access, you can use the right radial artery, the left radial artery, the distal radial artery, or you can use the ulnar arteries. The right or left femoral arteries are more or less the same, and the brachial axis is a special one that can bail you out in difficult scenarios and difficult situations. Know your anatomy. That's basics. You have to know your anatomy. You have to know where the radial artery is. You have to know what is near the radial artery. You have to know where to access it. The more distal you go on the radial artery, the more tortuous it becomes, as you can see on this picture. And most likely, if you use a non-hydrophilic wire, as most of us do, your wire can get stuck on the wall of the artery, that it may not travel easily, or it may face these difficult tortuosities. So it's very important that you try to go a little bit more proximal to the radial artery, more proximal to the actual head of the radial bone, because this is more straight part. Even though you can actually feel the pulse more stronger here, but the more you go more proximal, you're likely to see a straight run of the radial artery, and once you're inside it, it goes very smooth. Obviously, there's some calcified, difficult radial arteries. In elderly patients, you have to know how to deal with those. You have to be very slow and very careful, and you have to prepare the skin. You have to prepare the patient. You have to give them a lot of painkillers because this can be painful in some situations. It has huge advantages. It has actually changed significant risk of bleeding that we used to see in femoral access. It has lowered down our procedure risk, has resulted in early mobilization of our patients to go home, and early discharges. And the closure devices are a lot easier to deal with. And in some healthcare settings where cost is very important, and we don't have those fancy closure devices, you can use simple closure devices like just a little gauze and a tape, and you just apply pressure. However, ideally, you would want to apply patent hemostasis, and you have control over how much pressure you're actually applying. The patent hemostasis is important to maintain the patency of the radial artery after your procedure is finished, along with the heparin that you give for the patient, to ensure that the vessel remains open while you're actually stopping the bleeding. So you have to put enough air into the TR band. If you're using TR band or helix, whatever, you have to use the sufficient amount that stops bleeding while you can still feel the pulse, or you can still get pulse distal to the access site. Placing the TR band has to be very accurate because the angle that you come at the radial artery is not perpendicular. You come at 45 degrees or even 30 degrees to the skin. So your actual access point is a bit more proximal than what you see on the skin. And the radial band or the TR band has a green dot that tells you to put the access site or the actual puncture site just underneath that, but you need to be a bit more proximal. The pulse comes from proximal to distal, so if you block it even a bit more proximal, you're less likely to see bleeding. While if you were right on the dot or a slightly distal to it, then you're likely to cause proximal hematoma and more problems. So you have to be sure that you apply the right device on the right way. The heparin is very controversial. There's no real evidence on this. A lot of people do what they do from what they know, what they're used to. There's so much variation in training of how much heparin to give, if you're going to give any. I know a lot of senior colleagues never gave any heparin in renal arteries, but I don't think we have their data of the renal artery patency to be honest. But most of us are comfortable and familiar of giving heparin. The timing of giving heparin is also important, and the route that you're going to give it. So are you going to give heparin immediately in the radial sheath when you access the radial artery, or you're going to give it up in the aorta once you get down to the ascending aorta, or you're going to ask the nurse to give it in the vein? It depends on how you were trained, how comfortable you are about each axis and each method. But most of us do give heparin. We did see problems with heparin, especially in intervention, that we cannot afford not to have heparin on board. And I have an OCD about heparin not being given by the staff nurse appropriately. Sometimes, these cath labs are quite dark, and the nurses go on the other side. They give the heparin and they say it's gone, while the actual cannula may have been tissue. And in that particular patient that we had many years ago, the cannula was actually tissued and heparin was not on board. Procedure was very straightforward, very easy, no issues, but the patient died because of lack of heparin during intervention and had multiple clots that went everywhere to our coronaries for such a simple mistake. It didn't happen to me. I've seen it, but it's you learn from these experiences, and one loss is too many in these scenarios. This is preventable, totally preventable. So I tend to give it either in the radial artery itself or up in the aorta. I may forget once I go up the radial artery all the way to the ascending aorta. I may forget that I have given heparin or not, and I focus on engaging the vessel, especially if I'm doing intervention. If you're doing diagnostic procedure, you do have time, so you can give it up in the ascending aorta. The only advantage of giving up in the ascending aorta is not so painful to the patient. Heparin is very acidic, and if you give it in small vessel in the hand, the arm, they will feel a very hot sensation, severe hot sensation that could last for about 10 to 20 seconds, but it will go away very quickly. But that can be quite a bad experience to the patient, especially if you don't warn them in advance. So again, there's no right or wrong. Once you give the heparin, everybody's happy. But I like to give it myself rather than to ask someone else to give it. Doses of heparin, I don't know what people will say about that. Again, we don't have real evidence, but most of the time for any patient over 60 kilos, 5,000 heparin is usually a good dose. It's not a big dose, and it's not a small dose, and it's usually a good dose to maintain renal artery patency. But if you have somebody less than 60 kilos of weight, you probably should give 2,000 to 3,000 units of heparin. You can come and ask me as well, what about if patients have allergy to heparin? Luckily, they're very rare patients. They're not very common. Probably bivalirudin is available in North America. I've not seen it in UK or Ireland or Middle East. I think France also uses it sometimes. We don't have bivalirudin. I've never used it, but it's one good alternative option. Somebody told me they could use FFP somehow in cardiac surgery for those needing heparinization for the bypass machine, if they have resistance or if they have resistance to heparin, not allergy to heparin. The use of vasodilators is, again, very controversial. Some people, again, don't use regular vasodilators, and some people use regular vasodilators as part of their cocktail, where they give heparin, verapamil, and nitrate together into the radial artery as soon as they access it. Some people give verapamil alone, some people give nitrate alone. I'm more used to giving nitrate alone along with heparin on 2 separate syringes. Verapamil and heparin are quite painful to patients. They do feel it as very hot sensation in their hand and their wrist, while nitrate is usually okay. So talk to your patient while you're giving them this medication and preparing their drugs. Talk to them about what they expect. They're likely to tolerate it if you tell them in advance that this is coming. But if they suddenly feel something hot, they may think there's something wrong. Generally, I find a lot of people don't talk to patients, and then they see more difficulty, problems, and complaints, and terrible experience by the patient, even though they have done a good procedure, but they didn't really communicate clearly with the patient. Ulnar artery is one option to use if you have some difficulty with the radial artery, but the radial artery has to be present. If the radial artery is, say, taken off in a previous bypass, you should not use that ulnar artery because that's their only supply to their hand. If the radial artery is small, sometimes the ulnar artery is more dominant and it's a lot bigger and you can easily feel it. You can still use the ulnar artery, but you need to make sure that there is a radial artery pulse, and that pulse is not retrograde filling on an occluded radial artery, because sometimes the radial artery is occluded from previous procedures and you're not able to actually stream your wire through it, but you can still feel the pulse. In those situations, I recommend doing an ultrasound just to making sure that the radial artery is actually patent, even though it could be very small. Because if you have problems with the ulnar artery, then you will end up you can end up using that small radial artery. The body will end up using it, and it will hypertrophy and enlarge slowly, depending on what is required of the radial artery. But if it is absent completely, then the loss of radial ulnar artery will be disastrous to the patient. One important piece of information is the ulnar nerve runs very close to the ulnar artery, and ulnar nerve injury is one thing you should also avoid. By avoiding going from medial to lateral. You have to come from lateral to medial when you're accessing the ulnar artery. The risk with accessing radial artery, pain is very common. People do feel pain, different degrees of pain, could be mild, moderate, or severe. Especially if there is spasm. Sometimes if there's no spasm, people do feel the movement and do feel pain sometimes. But a lot of times the procedure is very smooth. Once you give local anesthetic, the procedure goes very smooth. Placing the sheath initially, patient feels pressure. When you give medication, they could feel this sensation of hot and cold sensation when you flush these medications. But you have to assess the skin as you pass your sheath through, because if you're pushing the sheath through the skin in a man who has a very tough skin, you may end up actually damaging the radial sheath. And if you keep pushing, you will end up tearing the radial artery, because that radial sheath is not smooth tipped anymore. So in those scenarios, a lot of people just do a small cut by using a blade, a sharp tipped blade, not the blunt circular tips, and you just pass 1 or 2 millimeters around your wire on one side, and that allows the sheath to slide smoothly through the skin. The most of the sheaths that we pass in the radial artery are hydrophilic sheaths, so they slip easily, but you need to wet the radial sheath before you pass it through the skin. Make sure you don't wet the whole arm of the patient while you do that. Just a little wet gauze will activate the part in the radial sheath that makes it slide smoothly. One of the things about radial artery is also radiation exposure. There have been reports that radiation exposure is higher than femoral artery because of where you positioned and the patient arm position. But as we moved on over the years, we've seen how much improvement on the protection and the shields that we use when we use radial or even femoral access. So it's becoming less of a problem. The complication that can happen if you're not careful, you can dissect the radial artery. There are two different types of wires that you push along the radial artery. There are some non-hydrophilic wires, and there are hydrophilic wires. The non-hydrophilic wires, they don't go smooth, they don't go easily. You feel resistance, and it's a very good wire in terms of giving you tactile feedback. So it tells you that there is something resisting, or there is something not smooth in that particular area. So you may need to move your needle a little bit, tilt it. You may need to stretch the skin to straighten the radial artery tortuosity with your fingers while you're actually pushing the wire slowly. Don't push the wire too hard. You have to make sure the wire is complying with you, especially when you have tactile feedback. Once you feel the wire is advancing smoothly, then that's the time then you take your needle and exchange into your radial sheath. Many times we've seen people going smooth, especially in ladies, because of the amount of subcutaneous tissue. Sometimes the artery just travels through that very smoothly, while the beginning of it is not smooth. So as soon as it actually exits the artery onto the subcutaneous tissue, those wires can sometimes move very freely, giving you the wrong sensation. So it's a matter of really time and experience that you get used to it. You probably will make some mistakes in the beginning, but over time you will realize it. Radial artery is still very forgiving, but if you have not accessed it properly, you'll end up losing that as your main access site on this occasion. And then you'll have to switch to another site. But if you're careful with it, it's actually very smooth and beautiful access. The hydrophilic wires, however, don't give you any tactile feedback. They just travel, whether in dissection plane or within the lumen of the vessel. But most of the time, you would feel very smooth movement when it goes through the lumen of the vessel, as opposed to a dissection plane. And over time, you'll also realize that. I've not had any dissection really with hydrophilic wires, but I have seen them going to the wrong branches, smaller ones, and sometimes you don't actually see. We don't do x-rays on the hand while we're accessing the radial artery, and that's just the way we all do it. But if there's any doubt, then you start x-raying, and then you start seeing the wire movement if you have any doubt. Get the C-arm over the hand can be quite tricky, so you have to get the table. First of all, you have to remove the second biplane machine. You have to use only one plane, and then you have to tilt the table to the side and push the patient all the way up the C-arm to be able to image the wrist and forearm area. So generally, we depend a lot on our skills in getting into the arm without using too much x-rays and trusting our own skills. It will take time. Post-procedure, there is a significant amount of radial artery losses. We occlude them, unfortunately, with multiple instrumentation, but with patent hemostasis and heparin doses that around 5,000, you're less likely to lose them, especially if the procedure was smooth and wire went smooth and the catheters went smooth. The size of the radial artery also is very important to assess it as you escalate your catheter size, because some times you need to plan a 7 French sheath through a radial artery, and that can go smooth through a large Caucasian man wrist, but it will not do so in a small Asian lady's hand. So you have to be very realistic and don't push things if you think the radial artery is very small in size. Nerve injuries, again, can happen. Less common with radial access, more common with ulnar access. And compartment syndrome can happen from significant hematoma. So make sure that at the end of the day, you assess your patients before they go home. Make sure they have enough sensation on the tip of their fingers, particularly if you're using the ulnar axis. But compartment syndrome can affect both nerves, median nerve and ulnar nerve. And it can affect the blood supply as well to the hand. So usually the patient complain of pain or numbness. So numbness is not a pleasant or acceptable complaint that the patient should go home with, you have to be careful. Sometimes you have a small hematoma, but sometimes you end up admitting the patient or even doing an ultrasound out of hours if it was out of hours to ensure that the patient has only hematoma, not a pseudoaneurysm that needing vascular intervention like injection of thrombin around it. And obviously, if there is bleeding, active bleeding, that's a different issue. You can deal with it straight away. Most of the time is bruises and discoloration while the pulse is still there and there's no actual pain or neurological symptoms. That's okay to accept. That's they can go home and you can follow them up as an outpatient. If there's an ipsilateral AV fistula, you should not use the radial artery. Clearly, you have to be clear about that. And in some centers, if patients are going for or newly diagnosed and renal failure and they're on dialysis by permacath, that they may eventually get a fistula, we try not to instrument the radial arteries to preserve it for future fistula. So we tend to go femoral in a lot of them, even though we're more confident now with our access to radial arteries and the medications and the closure devices that we're less likely to cause problems. However, if you can do a safe procedure through other access, then do so and give the patient the option to use that in other needs. Distal radial artery, this is something I've used maybe once or twice only in some difficult situations. The advantage of it, I find it mostly on the left radial side because it's much more natural for the patient to keep their arm on that position and much more easier for me to access their distal radial artery from that position. And it's pretty safe, and the closure is very simple. You don't need that much patent hemostasis. You just put a little gauze with tape and tape it around the access site, and it just doesn't bleed. It's really effective and it's very safe. I don't know why we don't use it a lot. Some centers, some of our colleagues probably now use it a lot more, but we're still radial school. We don't use distal radial artery commonly. Radiation protection, something that we're not really good at, but is really very important thing to do to protect us, to protect our families, to protect our staff that are working in the cath lab with us. So you have to make sure that you optimize the radiation protection settings that you have in the cath lab. Make sure your lead aprons are regularly screened for cracks. Make sure you wear them appropriately. Make sure they cover up to the knees and they have double layers on the front. So you can, that if you have two pieces, the skirt have to be tight on around you, not loose, so it doesn't fall during the procedure. And sometimes there are belts on them that you can use to hold the skirt in position, and it helps also to have the weight of the lead on the belt rather than on your back, so you have less back problems in the long term. For the single piece ones, it's always important to wear the external belt by lifting your shoulders up and putting the belt tight in around your tummy or abdomen, and that helps to take the pressure off your shoulders. It significantly improves how much weight you're carrying all along, because it's a long day and a lot of procedures. You have to look after your back and make sure you go home not as tired as you go if you don't. It's also very important that you wear thyroid collars to protect your thyroid. Dosimeters, I'm one of the worst people in wearing my dosimeters. If I'm not checked, I don't really put it on, but it's really important to monitor. Some dosimeters are fancy and they give you live how much radiation you're actually giving to the room when you put it on live, so you know how much you're actually giving. So it's really helpful to give you that feedback. While the information that you get afterwards, that is late news, you've already done the damage. But it's an important monitor to monitor your radiation. So I need to drink some water. If you have lead glasses, make sure they're appropriately placed for you, and they're if you use medical glasses, you need to get the exact lead glasses matching them, so you can see properly during the cath lab and you get protected. Lead hats are also very helpful if you have them, but not everywhere this is available. The table have skirts underneath, and they have mobile, flexible shield that you should always use them. I find the skirt under the table very, very important. But unfortunately, because of movement of patients coming in and out, the radiographer tend to keep it away, pulled towards their side. But you need to make sure that the skirt under the table is covering you all the way to your left-hand side. So it has to go all the way to your left-hand side. If you're standing in front of the patient and you're ready to go and you look down and you see the shield not covering you, then ask the radiographer to undo the shield and push it forward to make sure that you have enough radiation protection. There are flexible, as I said, table shields on the side of the shield, just similar to the under the table one. You just extend it above. Sometimes gets on the way of your hand, but actually it's very protective for the gap that you could have between the upper part of the under the table shield and the table. So that gap can leak X-rays, and that is the job of the flexible table shield to be lifted to cover you. There's in Northern Ireland we had mobile side shields. I find them really helpful. It kind of isolate you, keep you in a room away from the radiation head and radiation image intensifier. It comes on the side and it has a little C shape, so it can fit the patient trunk into it, and it gets also covered with the sterile material. And then you have got the ceiling lead glass that comes overhead that we have in most cath labs, and that helps to reduce the scattered radiation significantly. In my experience, limited experience in Sudan, people don't use it a lot, and it's pity that radiation protection is not great in many places, unfortunately. Rad pads, these are expensive little kind of square pieces that we put on the lower part of the patient abdomen to reduce the amount of scattered radiation, and they're very helpful. And then you need to make sure that the image intensifier, when you acquire the cine images, are as close to the patient as possible to reduce the amount of scattered radiation. A lot of times we have to take angulated pictures, but the more severe angulation you go to, the more scattered radiation you get in the room. So try to reduce that as much as possible. Desogi, am I running out of time?
No,
Are
no,
you with
no.
us?
No problem. No problem, inshallah.
Okay. I'll take a little longer just to illustrate a few things here, hopefully not too much.
Okay.
Most of us are right hand dominant, so we stand on the standard way, standing in the cath lab using our right hand and accessing right radial artery, which is easy. But if you're left handed, this is a position that you would put the right arm on if you are not comfortable using it in the normal position. And if you go to the left radial artery, you'll do the opposite. So you'd have to move the hand out this way, and you stand between the hand of the patient and the body to be able to access the radial artery a bit more comfortably with your right hand. But if a lot of time they put the patient hand by their side and they tie it so he doesn't move, that makes it really awkward for you to use your right hand and access the left radial artery. But a lot of times, if the radial artery pulse is pretty good, you can still do it that way. But make sure that you look after your back, look after your position, and also make sure that you're comfortable when you're accessing the artery. You have enough light, you have enough room to stand, and your hand is in a comfortable position. Prepare your wire, prepare your gauzes, because blood will be everywhere if you're not ready. Have your gauze close to the access side As soon as you access the vessel, it will bleed back to you in some needles. And the gauze should be just close to that area so you don't soak the whole floor while you're trying to advance the wire. The left radial artery axis is on the opposite side of the working side of the table. So ideally you should have a band or a strap to help supporting the patient position, and you should place that before you drape the patient. So you put it on, have it ready to go, and the patient put their arm where you want them to be initially, and as soon as you access it, you move into the last part here, having the sheath inside the left radial artery, and then you bring the hand across, and then you tie your strap on this position supporting the elbow, and you ask the patient to hold it. A lot of times we don't have all of that. There are a lot better, fancier one than the one illustrated in this picture. Much more comfortable for the patient and easier for them to hold it. And a lot of times we actually don't have these straps, and we just ask the patient to put their hand just over their umbilicus. We call it belly button in Ireland. So we used to say, keep your hand over the belly button. And that will hold the hand in position. If you are giving sedation, or if your height is not tall enough, you will struggle with your back. So it's very important to prepare a stool or something to help you to go across, because it can be quite difficult to hold the hand and work at the same time. In many scenarios, people don't like the left radial artery due to that. And obviously you're bending more, you're more closer to the radiation source, so you get yourself exposed to radiation a bit more. But if you're skillful and used to it, it can save you going through the radial artery, the femoral artery, and can save bleeding complication and can speed up recovery. And patients do love it because they know they have lost their right radial artery and their only option is either left radial or femoral, and femoral is becoming problematic for patients, mobilization and hematomas and bleeding and so on. These are the two types of needles that we use to access radial or ulnar artery. There is a needle on the left-hand side where you advance it into the radial artery as you feel it. Usually with this one comes a non-hydrophilic wire that gives you tactile feeling. So you have to use your as soon as I'm right-handed, so as soon as I access the radial artery and I find blood coming back smoothly, then I hold my needle in that position with my left hand, and then pass the wire with my right hand slowly over the needle and feel the wire as I advance it. So you hold it in that position, and if you feel resistance, then you may need to tilt. If you look at the tip of this needle, you could possibly be on the wall, so you need to kind of rotate it slightly downwards or to the right or to the left to make sure that your wire is more coaxial in its course when it goes through the radial artery. While sometimes you need to stretch the skin with your little and ring fingers to be able to straighten the radial artery as you advance your needle. So there's a lot of few things that you learn over the years to help you use that single puncture that you went through rather than coming in and out. The more manipulation and punctures you do in the radial artery, the more risk of spasm that you can get. And then this particular needle, I started using it more recently. I used to hate seeing it on the table, and one of my colleagues used to use it a lot of times. I didn't use it before, but I found it more available to me here, so I ended up using it. It's actually very smooth. So this is just like a cannula that we use in the veins, while this back end is detachable. If you want to reflush it, you detach that particular part and flush it through if you want to go and use it again. So it usually comes in as one piece, and you advance your cannula, this cannula, into the radial artery until you see blood coming back into this reservoir. As soon as you see blood coming back to this reservoir, you are inside the artery. But what you actually do, you go forward. So you actually go through the artery in two places. You go completely outside the artery, and then you stop a little bit. So once you stop, then you pull your needle, and your plastic part is somewhere past the radial artery. And once you take the needle part, the metal part out, there will be no blood coming back to you. That's the time you bring your hydrophilic wire that comes with this set usually, and pull your cannula slowly until blood comes at you. And usually it comes gushing very fast. Once you have it there, as soon as blood comes, then you stop and advance your wire into the cannula. And the hydrophilic wire usually travels very smoothly, and then you're inside the radial artery very smoothly. I find it a lot quicker sometimes than using the old system, but you need to be able to use any. And there are different types of needles. You have to be able to use any of them. It's the same method. I'm just going to talk quickly about fluoroscopy and image acquisition. To reduce scattered images, you should always, if you're going to use fluoroscopy to get to the heart, it should be in PA position, and then continue with your fluoroscopy if you need to, and use it only when you feel you need to. When we access the radial artery, we advance our 035J wire ahead of the JR4 usually that I use. And then you need to start screening the wire when you get about the right shoulder position. And it's something that you can measure from outside to know what position you need to start your x-ray at. And you can have your x-ray ready because your wire can suddenly go up the innominate and up the right carotid, and it can actually cause problems. So you need to see your wire once you reach the right shoulder and follow it through until you reach the ascending aorta. The engagement of the right coronary system is usually on LAO 30 to 45 degrees, depending on what you're used to. Most of the time, LAO 30 is enough, left anterior oblique. And then there's usually two views taken on the right coronary artery. Again, depending on how you're trained and how you do it. I personally find RAO view essential to be done in most of the right coronary arteries, because you can see more eccentric lesions on a 90-degree angle rather than just changing it from LAO to PA cranial. You'd need a lot more steeper view to be able to see it better. So I usually tend to do, as soon as I engage on LAO, I go cranial slightly with the camera and take a picture. And if I'm doing biplane, my RAO camera is ready to go, and my LAO camera is just engaging me into the right coronary artery. And then as soon as I engage, then I just ask to go a little bit more cranial, maybe 20, maybe 30 degrees if I can, and I go quickly. Right coronary catheters sometimes can be quite mobile and doesn't really stay in place. And by the time you actually move to cranial, it can disengage, and then you find yourself out, and you take a cine and it's not in, and you go back in again. So a lot of people, just as soon as they're in on LAO view, they take an LAO view and then they do a PA cranial. And that's pretty quick and reliable. Or sometimes they do an LAO and straight RAO. The problem with that is, if you don't do any cranial view, you're unlikely to be able to open the distal RCA bifurcation, so you won't be able to see the bifurcation clearly. So you must do a cranial view on the radial, on the right coronary artery. Some settings, if you have biplane machine and you take one picture on the right coronary artery, which gives you RAO and LAO cranial, or RAO and LAO, then you need to do a cranial view to see the distal RCA. At that time, you can move the other camera to lateral view, and that gives a beautiful view of the right coronary artery, which you don't do often. But if you have biplane machine, you will see it a lot more often. Left coronary artery, a lot of times, depending on the school you came through in training, but most of the time we engage on LAO view. But some people are quite used to engaging it on PA view. And then you take four corners. usually should be enough in normal coronary arteries. The four corners are the left anterior oblique and the iliocodal, areocodal, areocranial, and iliocranial. I may have skipped explaining what these views are, but I'm sure most of you are familiar with it. The A comes from the anterior that we mentioned earlier, that the camera is anterior to the patient, and then it could be left or right to the patient. And O is for oblique. So most of the views are oblique, except when it is just straight over the patient with no angle, then the O disappears and becomes either straight AP or a straight AP cranial or AP caudal or straight PA. So these are the general corners. Some people take modified views depending on what they want to see. If you do the four corners, sometimes you have to finish with a fifth picture, either a PA caudal or a PA cranial, depending on the tortuosity and the bifurcation. Your job is to do a diagnostic angiogram, not just to finish and go out. You need to be able to see, and that will be dependent on the variation of patients that we have on the table. There's so many variations sometimes, but the standard is usually the same. But make sure that you open all the bifurcations. You can see all the vessels clearly on two orthogonal views at least, and you can comment on the severity of the stenosis angiographically. There are potential difficulties. I'm going to go through three potential difficulty slides, and that will be it for today. Going through the radial artery, you could face tortuous brachioradial bifurcation. And in that situation, that's why I use a GR4 catheter behind the wire, because it's more straighter than JL catheters, and it's likely to help me to navigate my wire and direct it to the direction that I want with a better control than the more angulated ones. So the standard is if you load the wire onto the catheter, and then you go into the sheath with the catheter and then advance your wire. And if you feel resistance around the forearm or any resistance, you stop. If you don't feel resistance, you continue on and start fluoroscopy around the right shoulder. If you do feel resistance in the forearm, then you start fluoroscopy and bring GR4 closer to the bifurcation. That's because maybe there's some tortuosity or multiple branches around the bifurcations. And then once you bring the catheter closer to the bifurcation, you have more direction and more support for the wire to take the right and the biggest vessel, which is the brachial artery, that it would go up to. But these 035 wires are not slippery, so they don't tend to take calcification, bends, and stuff like that easily. That's why you would feel resistance. And the angle of the tip is quite a J, kind of almost U shape at the tip, and that makes it again hard to navigate through smaller branches. So if it is not passing despite bringing the GR4 a bit closer, while you're watching for movement and watching the patient for pain and discomfort, if that's not passing, then you try to Terumo wire, which is a very slippery wire and has 30 to 45 degree curved tip that you need a torquer at the back of it to be able to rotate it. But usually you just push it and it just goes through any tortuosity very easily. But it doesn't give you any tactile feeling, so you have to be careful. You have to visualize it as it goes up the arm. And if it is not going, you may end up using. You need now to see what the vessels look like. If the Terumo wire and the J wire, they're not both going, then you have to take an angiogram and warning the patient of the hot sensation in that area. And then you may end up using a coronary workhorse wire like BMW wire, which is 0.18 inch wide, that you can advance smoothly through those areas. But a lot of time, Terumo is enough. Some people advance the standard J wire in the beginning, and if it doesn't go through, they just exchange into Terumo and try without radiation, without contrast, without anything, and it tends to go through without any difficulties. You can monitor if the patient has any pain or difficulties, but usually you start seeing the wire tip in the right shoulder with no problems. Spasm is another difficulty that can happen, especially in females or smaller patients, or if they're very anxious. In some centers, we give sedation to every patient. This is not something that they do every day, and it's understandable that they're anxious. So we give them 1 milligram of midazolam and maybe 25 milligram of fentanyl, and that is usually enough to take the edge of the anxiety, and the patient is much more comfortable. In elderly patients, you have to be careful, and you have to always make sure that you have enough blood pressure to give these medications, and you're monitoring their oxygenation, as they may fall asleep and their oxygen saturation may drop. Giving vasodilators is also important to relax the radial artery. And you have to give strong analgesia. Sometimes you end up giving large doses of morphine. And what's most important is to give time for the radial artery to relax with those maneuvers. So I didn't mention high flow oxygen, but it's one of the things that you should give to the patient, along with strong analgesia, sedation, and vasodilators, and time. And that time, we're very impatient in the cath lab. We tend to just wanting to finish, and 5 minutes can be way too long. But it's very important that we give quite some time. And the way to know the ideal time is connect your sheath to pressure and see if the pressure tracing is slightly getting better. Initially, when you have the severe spasm, the radial pressure will be very flat wave, or very kind of little wave. Is not really a good wave to look at. But as you find the radial artery relaxing with all these maneuvers and time, the wave improves slowly, and that's the time probably you need to start manipulating things. Usually the first pass with the wire and the catheter, even if it is 5 French or 6 French, is usually fine. It's when you come out with that catheter, exchanging it to a different catheter, is the time that they get into spasm and pain, and it becomes really hard sometimes, and it does hold onto the catheter, doesn't actually release it to take it out, and can be quite difficult. And those situations, you really have to give a lot of sedation and time, and perhaps sometimes general anesthetic to be able to pull the catheter out, without causing too much harm. If you have tortuosity or calcification or difficulty in passing through a spasmodic vessel, having a stiffer exchange wire helps take the pressure off the artery and put it onto the stiff exchange wire on the second pass. The other difficulty is if you go up the right shoulder and you pass from the brachial artery into the axillary artery, up onto the subclavian and heading into the aorta, the origin of the brachiocephalic or the innominate artery can be quite distal sometimes, which makes it quite a U-turn to go all the way to the distal origin of it and then come back to the ascending aorta, and makes it really hard. And for those obese patients, sometimes it's actually the brachiocephalic is originating on the right place with no problems. However, because they're obese, their abdomen pushes the heart upwards, and the arch becomes almost like a square. So that makes the movement and the angles of access to the ascending aorta very tricky and very hard to navigate. So in those situations, you need more angulated catheter to be able to get you down the ascending aorta, because the wire will just go straight into the descending aorta, and you need an angle. So you need to, first of all, recognize where is the arch ending, where is the ascending, and where's the descending, because you would need to pull the wire back. You need to pull the wire back to give the catheter time to take its shape, but you should not move any catheter in the arch or anywhere without having the wire ahead of it before you reach the ascending aorta. So you advance your wire down the descending, and then you advance your catheter onto the arch. And the best view to open up the arch of the aorta is the LAO 30. That opens up the arch and can clearly see where your direction is. And then you place the tip of the catheter over the wire somewhere in the arch of the aorta, and you start pulling back your wire, and then as soon as the wire comes back into the catheter, you'll find the catheter taking a shape either to the left or to the right, and your job is to turn it to the right to give some direction of the wire onto the ascending aorta. This is kind of more difficult to be said than to be seen, and I think I would encourage you to watch some videos. I didn't really upload any on this occasion. Perhaps something I would consider in future to see how you access these tortuous aortas into the ascending aorta. And then as soon as you have your catheter into the ascending aorta, then you can continue with normal 035 wire that you used. But in some calcified, difficult situations where you have an elderly patient in particular, those vessels are not really compliant. So you have to support the catheter, because if you take the wire out and you start manipulating the catheter without the wire inside it, then the catheter will kink. And you have to be watching for kinking in the catheter, because then the procedure becomes an absolute nightmare if you develop kinking. And the way to avoid kinking is to watch two things. Watch the tip of the catheter as you rotate it, and watch the pressure tracing. If the pressure tracing becomes flat, or the tip of the catheter doesn't move as you turn the catheter, then that's the time to stop and undo what you were doing. So if you're torquing clockwise, you torque it back counterclockwise to release the kink. And if that happens, obviously that catheter becomes less and less usable, and you will have to exchange it to a different catheter. But first of all, you have to pass a wire through it. Otherwise, you'll go through all the difficulties again. So it's very important to keep an eye on the tip of the catheter as well as the waveform, the arterial waveform. Hopefully, will not take too long from here. Distal brachiocephalic origin, we just mentioned that. CP, we just discussed that. I don't know, it's not moving. Here we are. Then if a catheter kinked and you cannot actually undo the torquing, or you can undo the torquing, but the catheter kink does not get released and the normal pressure wave does not get reestablished, then you know you're in trouble. Then you try to advance the wire through it if you can. If you cannot advance the wire through it, then you'd have to snare the catheter.
Hello, Dr. AbuBakr. Hello, Dr. AbuBakr. I think we lost Dr. AbuBakr.
If the catheter tip does not, if the catheter tip was not moving, it's very important trying to pass the wire through. If you can't pass the wire through and the catheter is kinked, you have no option then to snare the tip from the other side to be able to straighten this kinked bend catheter in a small vessel. And you need to do that in a kind of in the aorta or the arch or somewhere in the aorta in a big vessel to be able to catch it. But sometimes you have no room to move it anywhere. But if maintain your tip of the catheter in the arch or the ascending or descending aorta, don't bring it back all the way into the brachiocephalic, closer to the carotids, unless you had to. But try to avoid coming back with the catheter that is not straightened into the out of the arch of the aorta. This is very painful, obviously, and you have to call for general anesthetic support to be able to put the patient in a comfortable situation, or as comfortable as possible. And then you move on. Once you take the catheter out, you could change your site, or you finish the procedure and decide to come back another day. But it's important to recognize this difficulty. Always watch pressure tracing abnormalities during engagement of the coronary arteries, dampening, pressure damping, or ventricularization on the arterial waveform or pressure drop may indicate either you're against the wall or you're against a very tight stenosis. So it's very important not to inject when you see these things. You need to position the tip of the catheter. You either pull it back or rotate it or do something to gain your pressure tracing, the normal pressure tracing. And then once you gain pressure tracing normal wave, then you make sure that the catheter is de-aired properly and the pressure tracing is normal. If you see damping pressure tracing and you're not against the wall and the catheter is moving freely in the aorta, then that catheter may have clotted. So it's important not to inject. That's the time people get stroke. It's important not to pass any wire through it. You just have to pull it. You just have to take it out. Don't push anything through the catheter that is damping and moving freely and not showing you any signs of normal pressure back. If your pressure drops suddenly without any reason, then you would question the connections of your system. Your manifold has to be connected properly. Sometimes the connection between the back end of the catheter and the manifold is loose and you don't connect it coaxially. Sometimes the pressure tracing becomes a bit inaccurate. One thing I didn't mention is to make sure that the zero of the patient is done accurately of those arterial lines and to make sure that it's positioned at the level of mid chest of the patient. And that is my last slide and my last comment. I really thank you for listening to me and taking the time to follow me on this lecture. Thank you all.
Thank you very much, Dr. AbuBakr, for this interesting talk. Yani really, we enjoy it a lot. And it is very educational, as usual. Thank you very much, yani, really, for your time. Any questions to Dr. AbuBakr?
Most welcome, my friend and my brother Dasugi. You're doing an amazing job, and you guys are in the middle of war, and we wish we could help even more. And this is a little thank you for all of you who are standing and treating in this difficult environment and very challenging environment. And we ask Allah to keep you safe and reward you in life and life after.
حياك الله دكتور أبو بكر، جزاك الله خير.
فيكم بارك الله فيكم. أي سؤال من الإخوة والأخوات زملاء؟
الست الكسائي بتاعت الأسبوع ده يا حسن ولا 24 ساعة بكتب يكفي شيء كلام فارغ كلام فارغ كلام بتاع
I take it there is no question.
I really, Dr. Abu Bakr, يعني I find it more easy for me when I find difficulty for my wire to go to the ascending aorta, and when usually it go to the descending aorta, I go with the catheter and then pull it down. I find it more easy than asking the patient to take deep breath and hold it. What do you think?
It depends on the problem. You see, taking a deep breath and holding it has to be done at the right time when the catheter is ready to move to the ascending aorta. This is very simple maneuver that you really don't have to do a lot except just asking the patient to take a deep breath, and it does work very quickly. If you are in a situation where the catheter or the ascending aorta has a very steep angle to the innominate artery, then taking a deep breath really doesn't really help a lot. If you have a JR4 catheter that went down the descending aorta and you start pulling it back, it may not necessarily fall into the direction of the ascending aorta automatically unless the patient takes a deep breath. And if it does even get into slight angle heading towards the ascending aorta, as soon as you pass the wire, the catheter is not bent enough to that direction that it will fall back with the wire again into the descending aorta. So taking deep breath in many times does help if it can be done effectively. Yeah, I think both ways can be done indeed.
Okay. Here in
Hello.
Sudan, Dr. Abubakar. Yes, welcome.
السلام عليكم.
عليكم السلام عبد الباقي، مرحبا.
Thanks, Dr. AbuBakr. Thanks, Disugi.
مرحبا
And all
أستاذ.
participants.
Most welcome.
Dr. AbuBakr, nothing can be added. Just I would like to stress on 2 points. First one is concerning the preparation of the patient. هذا الحديث الذي لا نميل عنه. You
نعم.
should know your patient in details. Very important. Our young trainee and doctors, they think it is just a matter of needle and doing the procedure. I think there is a lot of things to do before the procedure itself. This concerning the safety of the patient and even the successful of the procedure itself. The other thing is the technique. There is a lot of techniques you should acquire during your training. One of the thing is very important, the basic scientific or theoretical knowledge. Very important. You need to have some theoretical knowledge about what you want to do, what you should do. I remember when the radial artery came, just going and read the full text about the radial artery, anatomy, etc., etc. Then try your practice. Always you need to read one, do one, and teach one. And don't be in hurry. This is for our young generations. And seeing other people doing the procedure, very important. I saw many of trainee, either he's in the cath lab working, taking the needle, or away. This is not the right. I think you need to be without stress, near to the operator, see what the operator do, and you will acquire most of the important steps. You will see complication, how it will be dealt with, or at least you are in the monitor to see what the operator doing, and just as whether you are just an operator or not. This is not the right way. Thanks a lot, Dr. Awur.
This is Abdul Baqi Said Ahmed, right?
Yes.
ما I didn't recognize you, but I recognize you by your voice. كيف الحال يا المرافقون يحييكم والله.
Welcome, أبو بكر. How are
سعيدين والله
you?
بسمع صوتكم والله يا عبد الباقي.
Welcome.
شكرا.
السلام
شكراً
عليكم
جزيلاً.
دكتور دسوقي، ممكن أكلم؟
تفضل أستاذ دكتور عز الدين، مرحبا بك.
أهلاً
الله.
يا
أول
أستاذ عز الدين،
حاجة
السلام عليكم.
يعني حاجة دكتور أبو بكر يا أخي، والله أنت زي ما بيقولوا كفيت ووفيت. Very very well prepared talk, well delivered, have mentioned all the essential things in coronary angiography. وإن شاء الله ربنا يديك الخير والعافية. والدكتور دسوقي يا أخي ربنا يديك الخير والعافية، ما قصر. وأخي العزيز وصديقي عبد الباقي تحياتي له. He mentioned عبد الباقي mentioned الله يديك العافية يا عبد الباقي. عبد الباقي mentioned something which is also running in my mind. نحن وانت قلتها يا دكتور أبو بكر، هناك عندكم في السيستم you have to talk to the patient in the clinic عشان تلقى زمن تتكلم معاه وتشرح له وتاخذ منه يديك وتقول فاميلي. لكن احنا يجينا واحد من الناس بزوجته ولا زوجها ويقول يا اخي والله هو خواف عليك، الله ما تكلمه. فدي very important انه الواحد يشوف البيشنت concerns ideas expectations دي كلها you have to tackle it. بس السؤال الوحيد اللي عايز اساله هناك عندكم في ايرلند، هل you talk to the patient alone and the family alone or you talk to them together؟
طبعا سؤال مهم جدا جدا والله يا عز الدين، كتر خيرك. يعني this is very important. بالنسبه يعني البيشنت عموما بيجيك العياده عاده براهو، مرات بيجي معاه his partner ولا his wife ولا his daughter ولا his son، مرات بيجي معاه، لكن عاده بيكونوا براهم. فانت بتقوم تشرح له الحاصل كله، بتقول له يا اخي كده 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 these are the steps، وهو بيقوم بيقول لك الكلام، وانت انجيج معاه في conversation، بتعرف اذا كان هو فاهم الكلام اللي انت بتقوله ده ولا ما فاهمه، ولا عايزك تعيده له، ولا انت لما تقول له عيد لي الكلام ده بعيده لك كويس. لو انت حاسس ان انت confident enough، بيقوم تقول له خلاص لما تجي منو اللي حيجي معاك للبروسيجر، تديه الاوبشن ان هو يختار. مرات بيقول لك لا انا حاجي براي، لو في حاجه اتكلم معي انا، ده في ناس كده. وفي ناس بيقول لك يا اخي اي ماي وايف حتجي معاي وممكن تشرح لها برضه. فيلا اليوم ده انت بتاخذ الاوبورتينيتي يوم الكاث لاب الصباح انه تشرح لها. وعاده لما تمشي تشوف المرضى في الكاث لاب، جيب معاك نيرس، عشان النيرس تكون يعني your side of witness of what you said and what you did not say. لانه مرات يعني الفاميلي كان turn against you، لكن دي رير حقيقة في معظم الحتات، لكن sometimes can happen. فاتس important ان انت تتكلم مع الفاميلي اللي بيقدر يجيبهم لك بالبرميشن بتاعت المين بيشنت. لو البيشنت ما جاب لك زول، بس تو دوكيومنت ان انت يو ريكوستد ان البيشنت ده يجيب معاه فاميلي، لكن he did not want to، وخلاص تخليها على كده.
شكرا جزيلا.
العفو يا عز الدين، كتر خيرك، شكرا
الله
للمداخله
يبارك
والكلام الطيب.
الله.
شكرا جزيلا. لسه في حاجات كثيره ما تكلمنا عنها الحقيقه. يعني انا يعني صراحه I found يعني quite a lot of details، وبعدين يعني يمكن I was over detailing الحاجات، وفي حتات يمكن I was not detailing it much. I welcome الفيدباك بتاع الناس، ويعني things يعني can get better only with your feedback.
إن شاء الله. آخر سؤال دكتور أبو بكر. Here in Sudan we use the Jotkin 3.5 catheter to engage both the left and the right. We start usually with the left, and then with the same catheter we try to engage the right system. What do you think?
والله طبعا هي it's possible. يعني في many RCAs they have upward origin. فانت لما تمشي ب JL35 you have the chance to go upward في vessel زي ده. لكن لو عندك horizontal course من الاوستيوم او downward course من الاوستيوم، you have no chance. You will go into the conus branch and you're likely to be damping if you get into the vessel. لو عندك واير مثلا to manipulate it into the الكوروني ارتري، بعد ذاك you may be able to do it. لكن طبعا الايشو بيكون عندكم هو الكوست، مش كده؟
Yes. Cost and
ايوه
availability of the
ايوه.
consumables وكده.
وانت حقيقه practically انت you have already used that catheter.
مم.
Sometimes it just go in and it goes sit and smooth very smoothly without any issues. لكن if you're not careful you can dissect it. That's the concern. لكن you can give it a go gentle trial كده، لو مشت معاك اوكي. لكن ال cost will be a lot more expensive if we lose a patient ولا cause harm. أنا personally ما عندي a lot of experience doing that. يعني sometimes it happened just by luck. You know, it fell on that right vessel. And sometimes actually the origin بتاع ال right coronary artery can be quite challenging بال GR4. You may end up using JL to get in. And this is not something I've done commonly. Most of the Western trainees, I think they don't try that. لكن it's something that we will learn from you.
Okay, Dr. AbuBakr, what do you think?
Actually, the right now very rarely doing right radial artery because of material. We have very bad material, very bad wires, always inducing spasm. Actually, Dr. AbuBakr, Dr. Disugi, I prefer the left radial, especially in thin patients. And once we were, when we were at Sudan Heart Center, we start doing extended left radial, Dr. AbuBakr. Extended left radial. It is a very nice innovation. Just extend it, and there's a lot of manipulation. You hear about it, Dr. AbuBakr. You need a lot of manipulation in the cath lab environment. It's called left extended radial. Left extended radial. Because the pathway will be straight and the engagement will be rare. You need to have some changes in the environment of the. You take the monitor to the side of the C arm, and you stay in the left side of the patient. You need long tube from the to inject the dye. Anyway, it seemed to be interesting, but it's not done usually, or it is not usual.
Where is the arm positioned, AbuBakr?
The left arm is extended. The left arm is extended.
يعني if I go back to
90
that
degree.
picture, if I go to this picture,
90 degree. Yes. Yes. Like this. The monitor come in front of the operator, and the operator just behind this arm. It is done. I will send you the review of that.
And what's the advantage
about
of that?
this procedure?
What's the advantage of that?
Is as you know, the left. I think it is less. The spasm in the left side is less. You agree on that?
I'm not sure.
The spasm. The radial spasm. I think it is less. The other thing is it is straight. They say it is straight pathway to the ostia of the coronary arteries. Very straight, very easy to engage, very easy to manipulate the catheter.
That may be one of the reasons why it is a lot easier, because it's a straight one.
That was the main reason. It is if you stand from the left side or the right side, the left radial is more or less like the femoral artery. Whether you are in the right side or in
what about the radiation protection?
Side. The radiation will increase. Yes. The radiation also, the radiation protection will be manipulated. I think it needs some setup, some changing the setup of the room. I did it 5 times. I find it very easy, very enjoyable, but difficult to continue on that. Nowadays, very difficult to do radial in our setup. I was at Shendi for the last 2 years. We have very bad wires, very bad catheters, no dedicated catheter. Unfortunately, we reuse the catheter, but it is very difficult to do radial. Very infrequent times when we pushed, when there is no, when there is complication in the femoral artery or peripheral arterial disease or very obese patient, we do it, but with difficulty with our bad materials.
والله interesting. والله انتوا المرابطون غايتوا اجركم عظيم ان شاء الله. ربنا يثبته وربنا يجزيكم خير. والله يعني عملتوا عمل عجيب وفظيع، يعني ساعدتوا الناس المساكين وقفتوا معاهم، عملتوا بروسيجرز في اوضاع صعبه جدا جدا. ربنا ياجركم ويشفي مرضاكم.
آمين إن شاء الله. Here in our center, I publish many papers. We have يعني in our publications, the radial axis is in 10% of the cases. and 90% of our access was femoral. And يعني really I struggle a lot not to forget my skills in radial access, so I try to do it every now and then, in spite of lack of resources and these things. But it works. We don't have complications like spasm and these things. Alhamdulillah.
ايوه، هو طبعا الاسبازم يعني المشكله يعني بيكون multiple issues، يعني anxiety smaller patients. يعني في السودان اعتقد معظم البيشنت يعني African sizes والvessel sizes وكده بتكون better، لكن برضو الليديز لو خطيت لهم 6 French catheters they tend to struggle with that. الفايف فرنش يمكن تكون انسب. ما اعرف هل عندكم 5 French catheters ولا بتستعملوا 6 French by default؟
We use the 5 French for the diagnostic and 6 French for the therapeutic.
ممتاز ممتاز. الفايف فرنش ايوه ريزونبل. يلا مرات بنضطر نستعمل 4 فرنش كمان. عبد الباقي تفضل.
Dr. Abubakar, do you find any you prefer some catheters, whether it's dedicated catheter or the type of the company, يعني it is more, you know, the hydrophilic
ايوه
catheters, etc. etc. بس any
ايوه
يعني concerning the manufacturers, any يعني preferred catheter over others.
الكوردس catheters I find them a lot better خصوصا في الانترفنشن. يعني مثلا لما استعمل اكس بي 3.5 I find it better than using ال other types ناس فودا، مع انه كنت بستعمل فودا لغايه قريب يعني، لكن I find a big difference بالذات في الكومبلكس when I need support في السيركمفلكس ولا الار سي اي ولا الكالسيفايد تورشوز فيسلز. الاكس بي الكوردس كاثيترز بتقعد يعني تديك very strong support، while other catheters they just fall off as soon as you pass اللون بتطلع طوالي. من ناحيه بتاعت moving up the arm ما لاحظت انه في difference، لكن في الانترفنشن لاحظت انه فعلا في difference من الكومبانيز. الميك اب بتاعهم ذاتهم الكاثيتر ذاتهم the way they're made up يعني they're different.
supportive capability.
هاي السبورت يعني ديفنتلي ما عارف في حاجه في الوايرنج بتاع الكاثيتر الاكسترنال سبورت ستراكشر بتاع الكاثيتر ديفرنت حقيقه بتاعت الكوردس مقارنه ببوسطن والتانيين ديل ابوت وبوسطن. شايف الكوردس بالذات كويسه يعني.
You have the non-hydrophilic catheters from Tromo. They have thin catheters.
ديل فيري ثين، ديل اللي هو بيقول عليها شيثلس جايد، يعني دي من
Yes.
غير جايد. ايوه تديك 7.5 فرنش بتديك في الراديال ارتري، لانه الانترنال diameter بتاعها is very wide while the actual thickness بتاع الكاثيتر بيكون very thin. فيلا هم very flimsy catheters وكان kink very easily يعني صراحة، إلا لو عايز تستعملهم لما يكون عندك bifurcation lesions مثلا ومحتاج فعلا ل 7 فرنش ولا كده، والاكسترنال diameter بتاع الجايد 6 فرنش لكن الانترنال diameter 7.5. فيري سمارت ايديا يعني نقصوا الثيكنس بتاع الكاثيتر ودوك السايز اللي انت ممكن تلقاهم في 7 and a half فرنش سايز، لكن الاوتر
Yeah,
diameter
sheathless.
شيثلس. دي شيثلس جايد بيحطوها من غير هنا، بتركب الواير بعد ذاك تكستشينج الشيت بتاعك بتطلع وتركب الشيثلس جايد ده all the way up. يعني استعملتها مرات قليله كده في ايرلند ومره في كندا، لكن ما يعني صراحه يعني معظم
Yeah, long
الاحيان
dilator.
it's painful صراحة painful to work with. I don't recommend it. حسي عندنا ال 7 فرنش راديال كاثيترز ديل وراديال شيت 7 فرنش فانتاستيك. حتى مرات لما ما نلقى 7 فرنش راديال شيت بنجيب 7 فرنش فيمورال شيت. الفرق الوحيد هو طبعا انه الواير بتاع الراديال شيت ثين فيري سمول زي الكورونري واير كده يعني 0.18 ولا حاجه بالشكل ده، لكن الفيمورال واير ده ثيك thick wire يعني O35. فانت لما تيجي تخط to access الراديال artery اول مره بالنيدل you cannot pass ال O35 wire. You have to use a lot smaller wire يعني coronary wire ولا الراديال artery sheath
yeah, yeah.
واير. بعد ما تخط الواير بتاعك ذاك السبورت اللي بيديك للفيمورال شيث از فيري ليتل، ممكن تكينك الواير من غير ما تقدر تخش في الفيسل اصلا. فعاده بنعمل شنو؟ بندخل الشيث بتاعنا بتاع الراديال شيث، بنخطه كله اي حاجه ونطلع الحاجات كلها، نخلي بس الشيث قاعد. بعد ذاك بنجيب الفيمورال واير اللي هو اصلا نحن الواير العادي الجي او 35 جي واير بنخش به، وبعد ذاك بنعمل اكسشينج لهنا لانه a lot more stronger to take السبورت للراديال للفيمورال شيث. مشكله الفيمورال شيث القاعد في الراديال ارتري انه ما كوتد زي الراديال،
Yeah,
فلايكلي to
yeah,
cause
yeah.
more spasm, more dissection, more harm, more damage. لكن لو عندك dedicated radial sheath it will work fine. A lot of times the patient اللي عندهم very big radials they tolerate it with no issues. واحدة من الحاجات المهمة اللي أنا ما قلتها هي securing الاكسس نفسه، لأن أنت لما تعمل اكسشينج الراديال شيت ممكن يطلع برا خالص. ف... ففي حتات بيخطوا تاجا ديرم فوق الراديال شيت، وفي حتات بيخطوا تاجا ديرم تحت الراديال شيت وفوق الراديال شيت قبل ما يكون في اي ليكويد، يعني من غير بلد من غير سلاين من غير اي حاجه، واليد دراي. لو في بلد ولا سلاين بتبقى less effective، لكن انت you have to dry it، لكن برضه ما بتبقى as effective as لو ما كان في اي دروب بتاعت بلد في الفيلد. في ناس في كندا كانوا بيعملوا سوتشرنج عديد للراديال شيت ب نون ابزورببل سوتشر لغايه ما يخلصوا البروسيجر، بعد ذاك بيطلعوه. I find that السوتشر بصراحه سكيور، يعني انه مرات البيشنت بيتحرك ويجر يده ويعمل حركات بيعذبك في الشيث، ولو فقدت الشيث بتاعك بيجيك بليدنج كثير جدا. You have to be careful. مرات ما بتشوفه لغايه ما فجاه كده تلقى تحت الدريب بتاعك في a lot of blood.
Yeah, yeah. And there is a lot of new technologies in manufacturing sheaths and catheters.
نعم. ما في حاجة حسي في الفترة الأخيرة دي جديدة احنا شفناها في الماركت، يعني يمكن developing، لكن ما في حاجة كده different الناس بتستعملها
Softening
تاني.
the softening the catheter and sheath. It is more soft, especially trauma type of sheaths and catheters.
مم. يعني هم سوفتر على الفيسل، قصدك على الراديال مش كده؟
I think less you get less spasm.
less traumatic. ما هو لما كل ما يكون الشيث coated كل ما كان less problematic
Yeah.
للوول، يعني it slides over it
Yes, yes.
rather than it actually scratches it or يعني تضغط عليه، بتكون sliding over it. فانت عشان لما تيجي تدخل الشيت الديديكيتد radial sheath بيكون في external jacketed ولا coated layer does not activate unless you actually wet it. فبتلقى كتير النيرسز لافين ليك الشيت ده بويت جولد وخاتينه ليك في التيبل، انت اول ما تشيله هو بيكون ويت، لما تيجي تلزه بيزحلق في يدك، فانت لازم تلاقي زي دراي جوز كده عشان تقدر تلزه في الراديال سكين عشان يقدر يخش لك كويس. اهم حاجه انه بس ما تعمل له دمج، يعني تعمل فتحه كويسه لو ما دزنت سلايد، يعني مرات كثيره جست سلايدز يعني، لكن لو عملت الفتحه كمان كبيره بيقوم مع اي حركه بيقوم بيجي طالع عليك الشيء الثاني. فعشان كده بحاول انا يعني اتس بالانس، يعني بحاول ما استعمل البليد الا لما اكون هاف تو. والبيشنت ذاته يجيك مثلا فارمر كده ويده مثلا طف ومانيوال وركر ولا ميكانيكال، هنا بتحس انه السكين ده فيري ثيك، ما في حاجه حتعدي الا تعمل لها بليد. فانت الحاجه دي لازم تفهمها از يو باس ات، لانه انت يو كان دامج، وغير الكوست اللي حتعمله للسيستم اصلا اللي حتعمل مور بروبلم للمريض.
I think after the recommendation, I used to do incision first.
Interesting.
Is it like that, Abu Bakr?
والله في حتات انا
or
شفتهم
or or
بيعملوا هنا.
when you face problems.
وعادة ما قاعدين نعمل يعني 99%. انا شخصيا ما قاعد اعمل اي راديال هنا كاب قبل ما اخذ قبل ما
Incision.
اخذ النيدل، لانه مرات بغير البوزيشن بتاع النيدل، مرات بحس ان انا تو ديستال، ومرات بحس انه الواير في الحته دي ما ماشي كويس، بقوم بمشي مور بروكسيمال. فيعني انا اي دونت دو ذات. لكن بتذكر كان بيتر كارني ده كان واحد من الترينرز بتاعنا في كورك، كان اول حاجه بيشيل البليد، بيشوف الواير الفيسل وين، وبيعمل فتحه بالبليد، بعد ذاك يدخل النيدل ثرو ات. لكن ما شايف انه في particular advantage of doing that. بالعكس انت ممكن تعمل كم كات كده ده وتلقى نفسك في النهايه ما خشيت او عندك difficulty ولا هنا. يعني احنا لسه ما كوميتد ذاته للراديال ارتري لغايه ما نحن we have the sheath inside it. بعد ذاك بالزود بيكون more comfortable.
But one point, Dr. AbuBakr,
تفضل.
in the radial, you can go more proximal, no
نعم
problem.
نعم
But in contradistinction to the ulnar, you should go more distal.
صح. نعم.
This is
الراديال
one of
ارتري بيكون
very
more
important.
straight proximal، بيكون more straight
Yes.
proximal، ما في
And
tortuosity.
the bone structure, it is more distal
صح
beneath the radial ulnar artery.
صح.
The
هل حاولت؟
radial artery, you can go proximal as far as you can go, يعني up to the 1/3 of the forearm. Maybe you can go
مهم.
proximally.
مهم.
No problem going proximal to some
نعم
extent, some
نعم
centimeters.
نعم نعم.
Yes.
فيرلي سيف بصراحة، يعني الراديال ارت ده فيري سيف. لكن يعني ما حاولتوا تستعملوا السناف بوكس الديستال راديال ارتري ده قبل كده؟
I do it 3-4 times
What do you think؟
in big arteries, in
ايوه.
very big arteries. Just yes. Do you think is there any need for doing so? Is it popular
والله
now
هو
at your site, يا أبو بكر؟
ما انا عملت يمكن مره واحده ولا مرتين، ما عملته كثير ابدا. لكن بشوفه مور يوسفول في الليفت راديال مع البوزيشن حق الارم. يعني انا لما اكون خدت المريض واقف على يمين المريض وجايب الليفت ارم اكروس هيز ابدومين، طيب البالم بتكون بوينتنج داون، يعني الشيت بتاعي بيكون كفرد بين الهاند والابدومين. يعني وانس ان انا دخلت الكاثيتر بعدك ما بحتاج حاجه، لكن مرات بحتاج ان انا push الكاثيتر inside الشيث to pull it وpush وpull وروتيت لما تيجي تو انجيج. وانس ان انا انجيج بعد ده خلاص ما محتاج ان انا اعمل حاجه. فاي فايند انه الليفت راديال لما يكون في السناف بوكس يكون قاعد لك بفوق كده، اسهل لك انك انت تو اكسس الشيت من هناك مما تو اكسس ات underneath his hand. والهاند حقته تكون قاعده في much more natural position زي الزول الراقد خاطي يده فوق بطنه.
Yeah, yes. But
نعم
in the right side, you need to rotate the forearm, the hand
ايوه
medially to some extent.
ايوه
That will be more appropriate
ايوه. لكن
anatomically.
برضو الارم بتكون في ناتشورال بوزيشن. يعني انت لما تيجي تو سوبينيت يور ارم وفيس البالم بتاعتك upward that's not natural position.
Yeah.
البوزيشن بيكون قاعد.
The
ايوه
the conventional radial.
ايوه conventional radial. لكن لما تكون خاطيه للديستال radial البيشن بيكون literally خاطي his palm on his thigh، وده more natural كده
Yeah,
للبالم.
more. Yes, more ergometric.
ايوه. بعدين حاجه ثانيه، ما حد يستعمل expensive closure device للديستال radial. جست هنا اسمه شنو، ش- شطرطون كده ولا نايم معاهم حبة جوز وتضغط عليه بيجيب براو ما عنده أي مشكلة.
No
بيكون
need
اوريدي.
for radial band.
هاي ما بتستعمل التي ار بان معه.
No.
وبعدين شنو الديب بالمر ارش والحياة دي اوريدي بتكون طلعت معاي، انت بتكون بعيد منها
Yes,
ذاته
yes,
ما
yes.
عندك. بتمشي حته. يعني يمكن السوبرفيشال بالمر ارش ولا كده يكون contributing، لكن يعني it's very very safe
يعني
access.
there is no question of occluding of the radial artery.
لا 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 لا، ما بيقفلوا ما بيقفل
Yes,
خالص، بالعكس.
yes. It
المانيبيوليشن هو
is
المشكله
it is
بتاعته انه هو
distal.
ممكن يبقى اصغر شويه في بعض الناس، لكن عاده لما يكون في جود بلس في السناف بوكس معناته you can access it easily، والكاثيترز بيشيل لك كويس جدا. انا قلت لك انا بس انا يوزد يمكن once ولا twice ما بتذكر يعني، لكن I use it في انترفنشن وكان ما في اي ايشو. 6 فرنش كاثيتر مشت عادي. I did not try 7 فرنش. لكن ال 7 فرنش ده هو ادينا الكبار.
السناب بوكس يا دكتور ابو بكر is it popular at your
اي
site؟
في ناس
يعني a lot
كتير
of
بيشتغلوها.
operator do it
اي في
routine.
في
You
ناس
can
في
say
انجلند، في ناس في
routine or
كندا. في ناس روتين اللي بيعملوه في
routine.
كندا وفي انجلند وفي اعتقد فرانس ولا ايطالي، ما عارف، somewhere في يوروب بيستعملوه كتير. بعض الاوبريتورز بيحبوا يشتغلوا بالسناف بوكس ده.
Mm.
يعني I think it's worth trying it. يعني you may find it convenient and useful. لكن انت في النهايه انت ما بتحب الليفت راديال ده عشان الشارع ستريت.
ما انت بس يا ابو بكر هرسل لك هرسل لك الارتكل.
يعني لا لا، بكون كويس، انا عارف بكون ظريف جدا.
دكتور
وبعدين
عبد الله.
الليفت راديال بالمناسبه جميل جدا في الجرافت
الراديال
للليمه والحاجات
ارتري
دي.
سيرجيكال.
لا 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 لا،
اه يس يس.
للجرافت ستدي تمشي للليمه
Yes, yes, this is one
بمزاج.
of the indication. One of the
ايوه ايوه
indication.
ايوه.
Yes, if you have lima, approach will be easy.
لكن برضه ممكن تجي من الرايت راديال. احنا طبعا مشكلتنا كلها يعني في معظم الويسترن سيت ابس الريسك بتاعت الستاف، يعني الريسك الحاسي انتم معرضين نفسكم له هذه. this is huge radiation.
والله very huge, very huge.
huge radiation and you don't have to do that. يعني في شوية struggle، نعم الشارع ملولو شوية بهناك، لكن يعني بالذات اليونج اوبريتورز وكده you don't want to have lifelong high dose exposures. يعني it comes at a price.
You go to the lima from the right side.
ايوه you can. I've done it many times. لكن you need هنا اسمه شنو support wire. يكون شوية ستيف
Long,
عشان
long
ياخذ لك.
wire.
طبعا لونج وايرز معظم الحتات حسي،
Long
تخيل
should be
حتى
long.
للرايت راديال للنورمال للنيتيف كوروني انجيوجرام بيستعملوا لونج اكسشينج واير. ما يعني الحكايه بتاعت
To keep
الاكسشينج
the track.
كيف ذا تراك، وما في داعي للانجكشن وما عارف شنو.